Hello, I'm Tony DeMaria, the editor of JACC, here in Amsterdam at the European Society of Cardiology meeting, where there have been some really interesting late-breaking clinical trials presented. One, Spencer, I'm here with Dr. Spencer King, of course. He needs no introduction. One of the more exciting trials was the PRAMI trial, the concept of whether or not to approach the non-culprit vessel in a patient with acute MI.
Yeah, as you know, the guidelines all say that we ought to do the culprit lesion that caused the infarction and at least immediately stay away from other lesions, except for patients in shock or hemodynamic instability. This trial set out to find out if you randomize patients between opening the other arteries or leaving them alone, you could have a differential effect. And it turns out that the trial is very positive, but it's important to take a look at the endpoints. The endpoints are death, myocardial infarction, and refractory angina. And there are a number of things that I'd like to be concerned about in this trial. One is that the patients largely did not have anterior infarctions. They had mostly inferior infarctions. And you can imagine that a patient with the inferior infarction who had a culprit lesion in the LAD, a very tight one, there may be a temptation to open those. And perhaps that's good in some cases, even though it's not completely with the guidelines. The other point is that it's an unblinded trial. There's no way that you can prevent the patient or the doctor from knowing what was happening. So in an unblinded circumstance like this, we wonder if the patient who knows that they have lesions left behind that were not treated would there'd be more surveillance of those patients, and they would look very carefully with non-invasive imaging, which they did, much more so. Even in asymptomatic patients, they looked at non-invasive imaging. So again, there's some questions about it, but the combined endpoint is clearly in the advantage of doing the other vessels. But my concern is that we need to understand the nuance of this trial, because I'm afraid some will take this as license to do a lot of stent, a lot of vessels with a STEMI, whereas it stood the test of time that we stick primarily to the infarct-related vessels. So we need to know a lot more about this.
I agree with you. I find it a little bit unsettling that this new study, which was relatively small, less than 500 patients, stopped early as I recall, came up with results that are diametrically opposed to all of the other literature that has occurred, and in fact suggests a strategy that might be just as easily accomplished by a sequential PCI a day or two later. So I think more is going to have to be written. We're going to need more information about exactly what was involved there. Now, a study that I found particularly interesting was the so-called DECAAF study, and that study dealt with the efficacy of ablation of atrial fibrillation and asked the interesting question of what nature of intervention or pretest evaluation best predicted the success of an ablation for atrial fibrillation. And interestingly enough, what they found out was that it was the degree of atrial fibrosis as manifested on delayed enhancement cardiac magnetic resonance.
Yeah, not many people are doing this, I guess, but it was very clear from the author of this study that all the things you might think make a difference, how well you did the ablation, whether you encircle the pulmonary veins correctly and all that sort of thing, these things didn't matter so much. But what really predicted the outcome, by the way, the outcome was arrhythmia prevention, not stroke prevention. What really helped get a good result for arrhythmia prevention was the extent of fibrosis. And also the point was made that ablating that fibrosis was the goal now from these investigators, and that they are doing the MR pre-intervention, and then they're trying to ablate all around the fibrotic tissue as their primary effort in achieving a good result.
Yeah, now this was led by Dr. Maroche, who's been an advocate of this procedure, but it was multi-center. They did have a number of other investigators, and I think this is really going to stimulate a lot more evaluation, because the results of atrial fibrillation ablation clearly could be enhanced to get closer to 80 or 90% efficacy with a single intervention.
Sure.
Now, the ACCOAST trial was a trial that looked at the benefit of prasugrel given immediately upon diagnosis to patients with non-STEMI MIs.
Yeah, the idea here is that if you've got a non-STEMI and you're going to the cath lab and you're going to be investigated, should you wait until you get in the cath lab to give the 2B3A, to give the thienopyridine, or should you give it upstream as soon as you know about it? And this trial, importantly, did not send people urgently to the cath lab, but it was between 2 hours and 48 hours that they had to go to the cath lab. Now, when they got there, some of them, most of them underwent PCI, but some did not. So the randomization was between upstream half dose, that is 30 milligrams of prasugrel, versus no prasugrel. And then when they got in the cath lab, if they're going to have PCI, they got the full 60 milligrams in the patients who had not received it, and the ones who had received the 30 milligrams got another 30. Well, it turned out that this preloading, as you will, did not make a difference in the efficacy endpoints, the ischemic endpoints. There was an increase in bleeding with the pretreatment. And there are a number of ways you can think about how that might have happened. Maybe there was more antiplatelet effect at the time of the cath. Most of it was related to PCI bleeding. But patients, for instance, who were treated medically also had more bleeding in the pretreatment group, perhaps because they're the only ones who did receive the thienopyridine. They received the 30 milligrams upstream, but at the time of the cath, if no PCI was done, then no more 2B3A, no more thienopyridine was given. So I think it's interesting. I don't know that it's going to be game-changing in any way.
Yeah, there's been this persistent question that could you get benefit in these patients with non-STEMIs in whom PCI was going to be delayed if you immediately gave a thienopyridine. The other side of the coin, of course, has always been that if you give a thienopyridine and then it turns out that surgery is indicated, well, then you've got a delay of several days at least while the effect of the thienopyridine disappears. This study would suggest that the benefit of giving a drug early probably is not worth it, and if there's a likelihood that the patient might go to surgery, perhaps that could be held.
And I think one of the reasons for that is we have such improved stenting technology now, and also the patients who urgently needed to go to the cath lab were excluded.
They went anyway.
Yeah, so these are people who had non-STEMI, but they had settled down to some degree because they could only get into this study if it was 2 to 48 hours later that they were going to the cath lab.
Yeah, now the LINC study, interestingly enough, tested the question of whether or not mechanical cardiac compression in CPR would be better than manual compression, what we usually do. And this was based upon the fact that there's some evidence that manual compression often is not perfectly effective, and that oftentimes individuals get tired after compressing for a while. And also you can't give simultaneous defibrillation. And so they randomized two groups to manual CPR versus mechanical CPR, and the bottom line was it really didn't make any difference. Was non-inferior, but it wasn't superior either, and people are always around to do manual compression.
Yeah, the point was made that people wear out and that they can't keep it up for very long, and the manual and the mechanical device would keep doing it for a long time if you have to use long time compression. But as you said, in this particular study, they didn't show a difference.
Yeah, there was one study that really was very surprising, at least to me, in terms of making a major difference, called the In Time study. And the In Time study tested the hypothesis that if you took an implanted electrical device, either an ICD or a pacemaker, a BiV pacemaker, whatever, and you implanted with that the ability to telemeter the information to a station, that you would do better in those patients in the long run than if you just waited for routine medical evaluation office visits, so to speak. And what they found was that the patients who were monitored actually had a lower mortality and a better heart failure score than the patients who were not, something that would suggest a real benefit to this technological advance.
Yeah, you know, we have a lot of studies on home monitoring and things that have shown this kind of with nurse supervised things. The point that was made about this one was that the device, the technology is extremely high tech, and that the patient has no responsibility here. The patient gets it implanted, and all the information is sent automatically, and then the action is taken by the physicians and the caregivers. So it's maybe the wave of the future. We'll all be bionic sooner or later.
Yeah, one way or the other. So the last study to mention, I guess, is so-called PRAGUE 14. They asked a question about whether or not you could reduce the time prior to surgery that you withheld antithrombotic therapy without incurring any worse effects from the surgery, and by reducing the amount of bleeding. And so the answer was that in fact it didn't seem to make a difference whether you withheld aspirin or warfarin or thienopyridines for any less time than is currently advocated in the guidelines, some 4 to 8 days. You got the same surgical results with the same amount of bleeding. I think the problem here, Spencer, was this wasn't randomized, wasn't prospective, wasn't controlled. It was an observational study, and there's always the bias that the patients who are at highest risk for bleeding or highest risk for spontaneous thrombosis will have their medications adjusted because of that.
Yeah, a lot of trials today that some would consider negative, but a lot of information that helps us hopefully move things forward.
Yeah, no question about it. A really interesting meeting. Be sure to stay with us. For CVN, I'm Tony DeMaria.